Okay.
Okay, so anyway, I've created a game, Jeopardy, over your cardiovascular chapters, okay? And we're gonna play this game. Linda wants you to have some extra credit points for this game, okay? So I've got you broke up into 6 groups of 3. So is everybody in their group? No. Okay, we're gonna need to get in.
It's the same group that you did your team test in.
Yeah.
Those same groups.
Tracy, Nicole, and Abby. Veronica, Amber, Jay, and Courtney. Kristen, Kelly, and is it Valeria? Valerie.
Valerie.
Just Valerie? Okay. Sorry, Valerie. Terry, Carlotta, and Olivia. Chris, Malika, and Lori. Okay. Amber, Ann, Angela, and Katie. You're going to want to sit close enough that you can see.
No, I can't see. Do you make me look more?
Oh my God,
I hear that.
Just hear that.
You recorded what you said.
Okay, so we're going to play the Nice to meet you guys. We're going to play I've been here since 6:30 this morning, okay? So, we're going to play the game, and then we're going to have a lecture over heart cath and a PTA. What's a PTA? Percutaneous transluminal, what? PTCA. No, PTA. Percutaneous transluminal angiography, which is the legs. So we're going to look at the heart, we're going to look at the legs, okay? And I have some nifty handouts here of the heart and the vessels that they use and of the legs that I got from Galicia yesterday when I was at clinical. So I'll hand these out to you, okay? So I think this is going to be a fun game. And I guess we will get started. Okay. Okay, so today we're going to play a game called Jeopardy. We could do a nice long lecture, but would you rather have that over the subject matter, or would you rather play a game?
The game is good.
Lecture. We're going to get a little bit of lecture after the game, okay? But this is going to be a lot of fun, and there's several different categories. We've got the number, or the teams up here on the board, and you're going to start, we'll start out with Terry. And so let's get started here. So our categories are going to be pathophysiology, assessment, labs and meds, manifestations, and then miscellaneous. Okay? And has everybody seen Jeopardy on TV?
Yes.
So your answer is a question, right? It's going to be what is.
Do we
Most of
get a
these
daily
are
double?
what? Pardon?
Do we get a daily double?
Oh, you know what? No. I didn't have daily double on that template, so I'll have to watch for that. Or look for another one if I ever use this game again, because I think it's going to be fun. It was fun creating it. So, for every answer that you get right, you're going to get a point. And the points that are listed, and that's the fun part, okay? And whoever gets, the most is going to be the winner. Then we will look at those and determine which ones we will use as the 3 extra credit points that you're going to get, okay? Okay. All right, so let's start with Team Terry. Who will that be? What do you want to pick? What category do you want?
Assessment for 20, please.
Assessment for 20. Okay, your patient's walking in the hallway 3 days after experiencing a myocardial infarction. What clinical manifestation would indicate to the nurse that the patient was not ready to advance in activity? So think about it. If the patient is walking, what would you, no, it's theirs. What would you see in this patient if they weren't ready to increase their activity?
Tired.
Fatigue. Fatigue? What comes along with fatigue?
Short of air.
Shortness of air. What else?
Or sword. Walking.
Well, that'll be kind of a common thing, but if they're not ready to advance, shortness of air, fatigue,
Dizziness, low oxygen,
could be.
or ortho.
This is theirs.
Dizziness.
This is theirs. Okay, let's see what the answer is. So it's going to be what is
Fatigue?
fatigue? Is that what you guys all agree on that you want to have? Fatigue, shortness of air. Da, da, da. Everybody
Da,
knows.
da, 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 da. Da, 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 da. Da, 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 da.
And it is. What is
Shortness of air?
shortness of air? Okay. Oh. Onset of chest pain. Okay, why would that be? Why might that person be having increased shortness of, increased chest pain? 3 days after having a heart attack.
So their heart
This
has
is
to
open
work
for
hard.
everybody. Go ahead.
The heart has to work harder.
Part of their heart muscle is dead.
I'm sorry?
Part of their heart muscle is dead.
Could
So
be.
the contractility is not the same, they still haven't got their.
So they're
heart
having
to
some
pump.
angina maybe in there. Okay? So what medication might that doctor put this person on if they're having this chest pain, angina type of?
Right.
And not, yes.
The John Hopkins National Store Bud.
Yes, something with a nitroglycerin. Okay. So here we're going to write off this, and we will have Team Terry. Okay. Team Tracy.
Labs and meds for 20.
Labs and meds for 20. We already did assessment for 20, so you probably need to keep track of that. Okay. Your question is going to be, your patient is at risk for venous thromboembolism and is being discharged to home. The nurse teaches the patient to notify their healthcare provider if he has tarry stools. What medication would cause this?
What is Coumadin?
What is Coumadin? And they're being transferred to home. Okay, what is Coumadin? What is the
Why would they have that at
heparin?
home?
Yes, they do get, sometimes they do get sent home with that.
Sometimes. What is what? I've never seen Levodox.
Lovenox or enoxaparin, and that's a low molecular weight heparin. Okay? I hope everybody's making notes of this to use for their studies. Okay. That was Team Tracy. Okay, Team Chris. I got to do the sound, I have to do the sound next.
Thank you.
Miscellaneous for 20.
So miscellaneous for 20, okay. Okay, question. Your patient complains of chest pain. Upon completion of an ECG, it shows she's having an acute MI. Orders were to immediately prepare the patient for a procedure to assess and treat the MI. What is the name of this procedure? Da, da, da,
Da, da, da, da, da, da,
What is heart cath?
What is a heart cath? Is there another name for a heart cath? What's the full name for a heart catheterization? What are they doing? How are they going in? Think about that. Heart cath is good?
One moment, please.
Okay. So you want to just go with that?
Yeah.
Oh, there it is. It's a percutaneous transluminal coronary angioplasty, or PTCA. I called it and you corrected me. I didn't hear you say anything. Sorry. I didn't hear you say it. I was talking to them.
Before we started.
Oh, no. But there's a PTCA, that's for the heart. There's a PTA, that's for the legs. Okay? They're two different, they're done the same, but one goes to the heart, one goes to the legs.
Okay, which one goes to the heart, one goes to the...
Well, we'll get into it. Okay, Team Amber M.
We're gonna do assessment.
Assessment for 40.
Feel big.
Now, what is this? I'm supposed to do that. Supposed to go back to the beginning. Well, let's try this. Assessment for 40. Yeah, miscellaneous. Assessment for 40. The patient is recovering from a AAA repair. What's a AAA?
Abdominal aortic aneurysm.
Right, okay. So they're recovering from that repair. What will the nurse monitor for in her post-op assessment? This will be the priority thing to monitor for. Team Amber, yeah. Think about what they have done in this surgery and what would be a priority assessment. Da 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 da
Just like one priority?
Yes, the priority assessment. What is the major complication of that problem? When they have the AAA, what is the major concern?
Blood pressure.
Well, I want you to think this out, okay? What is the major concern when you have a AAA? What are you most afraid of happening? It's an aortic aneurysm. So what would you be worried about happening prior to the surgery? I'm sorry?
I don't know, bleeding.
Bleeding, right. You're worried that that's going to rupture. So they go in and fix it. So what is a priority assessment to think about after that surgery? Blood pressure is one, but why would they worry about the blood pressure? What would it cause? Bleeding. So what is your answer? What is?
Monitor the vitals.
What is? It's what is. That's how you answer the question.
What is monitor their vitals, specifically their blood pressure?
But what are you worried about happening? Bleeding. So what is?
Monitor your bleeding.
Yes. Let's see if that's right, okay?
Well, it's got hypovolemia, which is kind of,
Okay.
It's
Hypovolemia
bleeding.
is what? Hypovolemia causes, bleeding causes
Hypovolemia.
hypovolemia. Right. So you're going to be looking for bleeding because of the hypovolemia. Okay. Anytime you're putting a lot of hypovolemia, a lot of bleeding, and you've got hypovolemia from that, it is going to cause you to have renal problems. Have you guys talked about shock and hypovolemia at this point? We'll talk about that next semester, okay?
So how do you monitor hypovolemia?
The bleeding.
But how do you monitor it? You can't see bleeding
No,
internally.
no,
So
we're
how
talking
do you
about
monitor
internal
it?
bleeding. You'll be looking at their wound, okay? Because
So
they will
you're
have
just
a large
assessing a wound.
Are
You're
you looking like
assessing
if they're
the bleeding of that
hemoglobin
wound.
or?
You're going to monitor their vital signs, like she was saying, because what is one of the prime things that happens to your vital signs when you have bleeding? What's going to go down? What's going to go down?
Blood
Blood pressure. What's going to go up?
The
heart rate.
The pulse will go down too.
No, it goes up.
Goes up with the.
It goes up. When you have bleeding, you've got that hypovolemia occurring, you're going to, that's part of it. But you're going to be looking for the hypovolemia, which is monitoring of the bleeding and heart rate, blood pressure, those kinds of things. Okay. And then what's a myocardial infarction? Heart attack. So as a result of the hypovolemia, they could in fact have a myocardial infarction. Now let's see if this works. There we go. That one worked. Okay, so that was Amber. And they got 40 points, right? Was it?
Yeah.
Okay. Okay, then our next group is going to be Krista. Team Krista.
We're doing miscellaneous for 40.
Miscellaneous for 40? Actually, it'll be the same thing. It's not going to change the question. Isn't that what Amber had?
No, I had assessment.
I had assessment for 40.
Assessment. Let's get that. All right, so now we're going to have miscellaneous for 40. Okay. Question. Your patient has a new order for lovastatin or Mevacor. You know that he should not be prescribed this medication. What would you have seen in his lab work that would have alerted you to this? So did you read about lovastatin in your reading?
I'll have to stand up. I can't read the question. I'm blind.
Okay.
The patient has a new order for lovastatin. You know he should not be prescribed this medication. What would you have seen in this lab work that would have alerted you to this?
What is? What's liver enzyme?
yes,
And how
you
will they-
got it, yay.
There'll be elevated.
She got it.
Elevated liver enzyme. Yay!
Yay.
It's time to go home. We've got home kids. All right, the next one's gonna go to Veronica. Okay, Team Veronica.
How about labs and meds for 50?
Labs and meds for 50, gonna go for the big one. You get a report on your patients. One of your patients is still getting Coumadin while receiving heparin. What is your best course of action?
Well, we just went over this, that Coumadin takes 72 hours to become effective, so you might not necessarily do anything, depending on how long they are, but you probably want to monitor what is monitored waiting? What is monitoring their INR?
Well, what's your best course of action? What are you gonna do?
Just give as per our INR is.
This isn't your question.
See what their INR is, because.
And then, if it's within the normal limits, what are you gonna do? Or if it's.
Follow the orders as directed. If their INR is elevated, then you contact the provider to see about adjusting either one.
But you're reading into the question.
Well, I mean, I'm
Your
just trying to
patient's
figure it
still
out.
getting, oh, that's not helping you do. Still getting Coumadin, receiving heparin, and what are you gonna do? Is that okay? Is that not okay?
That's why you would want to check their INR, I would think. I mean, I don't, what is the report on them? Is it, it's normal?
But you're reading
supposed to,
into it.
right.
What's your best course of action? You already have the order to give them both.
I mean, I don't see. I don't know why we wouldn't, I mean, we would check their INR, and if it's within normal limits, can give the medication as ordered, I guess. I don't.
Okay, so
know
what is,
else.
give medication as ordered? Is that your answer? Yes. Because the doctor's already checked the INR.
Right.
And then he's prescribed to go ahead and, your patient's probably getting ready to go home. So they, like you said, it takes a while for the Coumadin to take effect. So they're gonna still receive Coumadin and heparin together until your lab work is where the doctor wants to see it, and then he'll be see the heparin. So you were on the right track. You just added too much more into what the simple answer was, just give it. So good
Did
job.
you get the answer right or not?
So at this point, we've got Team Veronica with 50, Team Krista with 40, and Team Amber Ann with 40. All right. All right. So let's go back to Team Tracy.
Terry.
Oh, sorry, couldn't see. Team Terry, assessment for 50. Assessment for 50. Okay, your question is going to be, patient presents to the ED complaining of nausea, pressure in the chest that radiates to the jaw and left arm, and is experiencing shortness of air. What might this patient be experiencing? Go for it, Cynthia.
What is a myocardial infarction?
What is a myocardial infarction?
Yay!
All right. Now it's Team Tracy. This way.
Let's do manifestations for 30.
Manifestations for 30. Your patient's complaining of pressure in his chest that radiates to his jaw and left arm.
We just did that
That's the
one.
same thing.
Can we do 40?
We'll just answer it.
Manifestations for 40. Okay. No manifestations for 30. We use that. Okay, for 40. Question is, patient complains she has chest discomfort while performing moderate exercise, and it goes away with rest. She states this has been going on for several months. What disease process do these symptoms indicate?
Is it stable and what is stable angina?
Okay, let's look and see. What is stable angina?
Yay!
Hey, good job. You got it. Okay, Team Chris.
What did they just do, manifestations for 30?
Uh-huh.
I want to do for 40.
No, we
Oh,
didn't.
we just
No,
did
30 was the one,
Well, then
they
let's,
did 40.
then let's do 50.
Manifestations for 50. Your question will be, your patient complains of pain when walking a distance of a block. He also has an ulcer on his fourth toe of his left foot. What is the name of this symptom of peripheral artery disease?
We did just talk about that.
Intermittent.
Have any idea yet? What are some of the symptoms of peripheral artery disease? Would be pain in walking,
Yes.
and what is that called?
Is this called dependent rubor?
What's rubor? What does rubor mean? Anybody? What is
It
rubor?
may cause, it may occur with extremity lower.
The river is the red purplish color.
Right.
Yeah.
This is pain when walking a distance of one block.
Intermittent claudication.
Yes.
Is that your answer? Did you discuss
What,
it?
is that our answer? Sure. What is intermittent claudication?
What is claudication? Yay! Good job. That was like 50. Okay. All right. Team Amber. M.
For 50.
I'm sorry.
Labs for 50.
Labs for 50. Actually, we did labs for 50.
Can we do patho for 50?
Patho for 50? Okay.
I'll give it all the reports.
Okay, patho for 50. Question is, this occurs when myocardial tissues are abruptly and severely deprived of oxygen, blood flow is reduced by 80 to 90%, and ischemia develops. What is this? We're at 50 points. Myocardial infarction.
Because remember, we just went over this, y'all, didn't she say ischemia happened and then cell death is infarction?
We talked about that in atherosclerosis.
Yeah, but was it an atherosclerosis?
Yeah.
We,
Well, I remember it,
The
and I was right.
myocardial infarction happens as a result of atherosclerosis.
So I was right.
Okay, let's go with Team Krista.
Miscellaneous for 50.
Miscellaneous for 50. All right, the question is, upon assessment of your patient, you notice he has dependent modeling and no hair in that area. What is this condition called? He has no, or dependent modeling and no hair. What is this condition called? Find it yet? Have any idea?
What is peripheral arterial disease?
Peripheral arterial disease. What is peripheral arterial disease? Okay. Peripheral arterial disease causes arterial insufficiency. Okay? Okay, so. Okay, let's go on to the teen Veronica. Let's see, we've done an assessment for 50, a miscellaneous for 50, manifestations for 50, capital for 50. Meds and labs for 50. Labs and meds for 40. Question is, your patient has atherosclerosis. What two meds are prescribed most often for this disease process? Atherosclerosis. I always want to put an R in there.
Well, our first one is what are statins?
What are statins?
Specific medication?
You can give me a specific.
Yeah, do you want just, is it along the insulin, or do you want, I mean, do you want like, are you looking for a class of drugs?
Like a black out, like your statins, what else?
An antioxidant.
An antihypertensive. Statins and an antihypertensive is their answer. So
Those are both statins.
Oh. Okay, Zocor and Lipitor are both what?
Statins.
Statins. Okay, good job. Okay, so everybody's done two. So now we're on at the third round, and that's going to be our final round, okay? So then we'll start out with Team Terry again. So it's the lower extremities. Partial or total arterial occlusion. What is this condition? Oh, a 50, right? You got a first one you didn't get, second one you got 50, and the third one you didn't get. Team Veronica is 110. Team Krista, 120. Comment. 40, 50, and 30. Team Terry, 100. Team Chris, 80, and Team Amber, 90. MI, right? Which is what? What are the symptoms of having a
Right shoulder pain that goes to your jaw.
right shoulder?
I mean left.
Okay.
Left, yeah.
Okay.
And
Left
then
shoulder pain?
shortness of air and angina.
Which angina is what?
Pectoris angina.
Which is what?
Chest pain.
Chest pain, okay. Okay. So, we also talked about a percutaneous transluminal coronary angioplasty, or PTCA. And what does that do? What do they find out when they do a heart cath? They're going to go in and they're going to look at what blockages you have in your arteries of your heart, right? Also, I don't know, you guys all have your books on your tablets. On page 844, it's going to discuss PTCA. So that might be something good for you to look over. I've also handed out a diagram of the heart. And this diagram is going to show the vessels that they most often go in and stent or open. They can balloon those open, or they can put a stent in. But at PTCA specifically is for people that have single or double vessel disease, and they have either discrete, proximal, or non-calcified lesions or clots in there, okay? So that's why they usually do a PTCA. What it won't work to fix is if they have complex clots. So when the cardiologist gets into the heart, into one of those arteries, they're going to look at the complexity of that clot and where it's at, and the amount of the myocardium that might be affected if they stent this, or if they open this up for the revascularize it. They now also use the PTCA for those lesions that are in the left main artery. So if you look on your diagram, you can see the left main artery. See the right artery. Yes. I was looking up here, but it only has it here. So this comes across the aorta, and it comes around onto the back of the heart. Where it's got the dotted lines, that's back behind the heart, okay? So that's the left main. So they can also use it for that. Even though there may be a large amount of myocardial tissue at risk, they will still do a PTCA on that. They would then use stents within that. So they'll go in with a guide wire in through the groin, and they would have a balloon on the tip of that. And when they get to the blockage, they can open that up. And what that balloon does is press all of that plaque up against the walls of the artery. Okay? That will last for a little while. But normally that will reoccur again, especially if you smoke. Okay? So what they will do is they will put a stent in there to hopefully hold that open longer. Has anybody seen a stent that they use?
Mhm.
Do you know what a Chinese finger torture is? Where you put your fingers in that thing and you pull? Well, they look like, kind of like that, kind of a mesh looking, but they're very, very tiny because they have to be able to fit inside your arteries, so they're really small, but they kind of look like that. The first time I saw one, that's what it reminded me of. In the past, whenever you had an occlusion in that left main, they would do a cabbage. What's a cabbage?
Coronary artery bypass.
Right. But now they're finding that they can stent these, and they have a pretty good lifespan with a stent in there. Those stents have a good lifespan.
10 years? A little bit over,
Pardon?
is it 10 years, a little over that?
It depends on a
It
stent.
depends on the person also if they change their lifestyle.
Exactly.
Okay.
And it's nothing special. So we also talked about on those slides in the game that they can use the heart cath or the PTCA for an evolving MI. So if somebody's having an MI, they come in, and depending on what type of an MI they're having, they can take them to the cath lab and perform the PTCA on them, okay? They can, it can be done alone, or they can use a thrombolytic therapy. And what's thrombolytic therapy?
Destroys the thrombus.
And what does it do? It breaks it down. So it's a thrombolytic therapy. So how do you get the patient ready to have a PTCA? What is your nursing responsibilities? What do you think that the doctor would order? They usually have standing orders that go on the chart when they get or they get
They're
their.
usually NPO and then they're sedated.
And what else do we have?
They use the medication.
They do labs. When do they usually draw the labs?
In the ER.
Like the ER.
Well, no, we're already at the procedure area, and we're getting them
We're
ready.
drawn before.
We're not on the floor, they're
Before.
They do them before.
before. A lot of times what they do, when they're starting their IV, they'll draw their labs as they're starting their IV. So we're gonna get their labs drawn, they're gonna get their IV in. What else do you think goes on?
Their medication.
Any medications? What kind of medications do you think they give pre-heart cath? When we start that IV, they're gonna start a normal saline drip, usually around 125 an hour, okay? So what other medications do you think they give?
Give a vasodilator.
A vasodilator prior to this heart cath?
I'm guessing.
Okay. Sometimes they'll give Plavix. Have you heard of Plavix? Okay. Or what is the generic name for that?
Clopidogrel.
Right. Sometimes they'll use one that is called Efficient, or Effient, sorry, Effient, that's an E, not a C. And that's another antiplatelet drug. So do you guys understand the difference between Plavix and Coumadin? What the difference is?
Plavix is a platelet aggregate,
Right. And Coumadin is
an anticoagulant.
anticoagulant. Okay, so had Linda talked to you guys about what the clotting cascade is? Okay.
I've heard it.
Yeah, and that's all you need to know, is there's two sides. Coumadin works on one works on anticoagulation, one works on antiplatelet, okay? You'll learn a little tiny bit more in your RN, but not a whole lot, because it's extremely.
Does it have something to do with the fibrin elastin?
Mhm. Yeah, it has, yes. You read a little bit about it, huh?
I work for a cardiologist. They give me
Okay,
prep a
that
lot.
explains it, you probably know a lot then. Okay, so, sometimes they'll be Plavix, then they decide after the cath that they're not gonna be able, they're gonna have to go ahead and do, coronary artery bypass graft.
Okay, so you sent that.
That they would have to
She
wait
told me to
about
leave
5
my
to 7
original
days or
notes
so
in there, so I went in
before
there and
doing
deleted
that,
them.
because they've started
Put the
that
state in instead.
antiplatelet,
She
and
had
they
both
don't want
copies.
bleeding
Okay.
to occur.
Okay.
They want the chance of bleeding to be lessened.
My grandfather, He's never had a heart attack, but he's had 2 of them surgeries, and he went in for a stress test before he had his second one, and he had Plavix, and so his stress test was bad, and his calf was bad, and he had to go off the Plavix, and they were gonna try to wait 7 days for him, for that to happen, but they wouldn't even let him go home while they waited for that. They were so worried that he was gonna
Go ahead and have that.
drop within a night. I mean, they ended up doing it like 3 or 4 days later. They didn't even wait the full 7 days. They ended up waiting like 3 or 4 days later, and they didn't even let him up out of bed to go urinate.
I was gonna say, I know a lot of times, a lot of surgeries, we don't even let them stop the Plavix at all. Because it has to be 1 year uninterrupted therapy, period.
Yeah, because sometimes
Well,
somebody
usually they're
that's
going
not,
for a bypass, so they wouldn't
Right.
even.
yeah, this is a different situation, but sometimes doctors that aren't cardiologists will, like a surgeon, if they have to have, gallbladder surgery or something, they'll stop their Plavix. And then they end up having a heart attack because they've stopped the Plavix. So if you have, any of you have to have that done, any family members, friends, be sure to tell them that they need to make sure they tell their surgeon, that they need to consult the cardiologist before they do the surgery and find out if they can stop the Plavix.
My mother-in-law takes Coumadin for a stroke, and and she had to have a heart cath, and her cardiologist took her off the Coumadin, and so 3 days leading up to her heart cath, took her off the Coumadin, but we had to give Lovenox injections twice a day, just so that she still had the.
Yeah, so you understand they do Lovenox at times. I've had to do teaching on Lovenox when we were doing some time with it.
So I have a question. So if they have a PTCA and it doesn't work, then they would do a catheter?
They can, yes.
Okay, all right, that was my question.
Mhm.
And then they'd have to hold it for 7 days or 2
Or they may not have even started it yet.
Okay.
Because a lot of times they don't start Coumadin until after the heart cath.
But if they did before?
When it
Okay.
first came out, they never gave it before the heart cath. During the heart cath, they would give heparin. And we'll talk a little bit about that here in a minute. So when you first come in, let's say you're coming in for a heart cath and that's what you're going to have. Then your doctor, he's done testing, you have to have a heart cath. So they send you into, at Galicia, they send you to the outpatient area. So when you come in, it's up to the nurse, and that's what we need to know, right? We don't really need to know how they do the heart cath or what they find out. We need to know what we need to do as nurses. So what they usually do is you have to do a full admission assessment. It takes quite a long time to do a full admission assessment. That's lots of questions on the computer. You get their meds, you get their entire history. It's quite the ordeal. So the nurse would complete that. Now, as LPNs, you don't do that. That's up to the RN to do that. LPNs are not allowed to do assessments, right? You can do them under the
Supervision of the RN.
yes, you have to be under the RN, and it cannot be the initial assessment. Okay, it can be follow-up assessments. So the RN would do the full history and the assessment. They would do, usually what I have my students do is they go in and they're going to do blood pressures in both arms. Why do you think they need to do blood pressures in both arms?
Because there could be an occlusion on one side.
There could be an occlusion on one side, right? Okay. They're going to do their height and weight. They need their weight in kilograms because that's how they're going to do some of their meds. They're going to do an EKG. And they're going to prep the groin, okay? And you clip the groin, right? You don't shave. They don't like you to use that word in your documentation because shaving could indicate that you could do what? Cut the patient, nick the patient, which is impaired skin integrity. So then you have electric razors and you prep the groin on both sides usually. They usually like to go in on the right side, but sometimes something happens, they can't get in, they may go to the left side. Like I said, they're going to start the IV, they're going to get their blood draw off of that, they're going to start their normal saline drip. And then when they go to the cath lab, they're going to be under fluoroscopy. In fluoroscopy, they are able to see up on a screen exactly what's going on. You've got people that sit back behind the screen and they do all the running of all the machines, all the video type stuff. And then there'll be the nurse out with the cardiologist and also the cardiologist himself. They're going to give them some medications to relax them a little bit. They don't really want them to be asleep. They're going to insert the guide wire in through the groin, through the water artery, the femoral artery, right? And then they're going to bring that all the way up and go into the heart. And they're going to look at, usually kind of go through and look at all these vessels that will show you on your diagram. They're going to run dye into those. So what do you think we're going to be checking for before we run that dye?
Allergies. Are they allergic to shellfish or iodine?
IV contrast,
Pardon?
IV contrast, if they have an allergy.
Right, if they have an allergy, but what else? What, right, kidney function.
Oh, creatinine, sorry.
Yeah. So then that guide wire is going to have the balloon on it. They'll go in, like I said earlier, they'll open up that vessel. They may put in a stent. Usually on a PTCA, they don't stent. It's usually diagnostic. They'll balloon it. And a lot of times, your cardiologist, they have to be able to do stents. Not all cardiologists can put in
It has
stents.
to be an interventionalist,
Yes, an interventionalist.
not just an electrophysiologist.
Right. So a lot of times you're going to see them go in, have a heart cath one day, the next day they're going to go back in for the intervention, which would be place the stent.
Didn't Alicia get in trouble for that though?
For what?
They would have patients come in, do the heart cath, and then have them go home, come back.
I don't
They can
know about
charge
that, but
that.
they do it still. And they're not the only cardiologists that do it.
You're going in the same way to place a stent as you are a heart cath. So why put the patient under sedation? Why do that twice? Why not just do that? And then the first time you need a stent, why not just do it that
I
way?
can't answer that, I'm not the doctor. But I know it's done at more than at Volusia. Okay, so they do the procedure, they do whatever they need to do in there. But as they come out, and during that time, they may be given a boluses of heparin too. So they're going to be running, what lab do they run for heparin? PTT, okay? They're going to have to do some kind of a closure to that. They have different types of closures now. They're usually collagen that they can close that off with. Sometimes they do it, sometimes they don't. Sometimes they leave the lines in. And when they go back to the interventional unit, they will check the PT or PTT, and then they will decide when they will pull those lines. They have a parameter of what the PTT has to be before those lines are pulled. And then it's up to the nurse to pull those lines. If they're back in the cath lab, I'm sure it's probably still nurses in the cath lab that pull them too. But when I worked in cardiology, we pulled all the lines. But they didn't have those star closures and all the fancy little collagen closures that they have now that actually plug that incision.
When you say they pull the lines, what do you mean by they pull the lines?
They leave there's lines in there that go down into the femoral artery, and they've used them to put that guide wire in. They've used it to do monitoring, and so you have to pull those lines
How
out.
long are they? And that's pulling that out of the femoral arteries, is this the practice for RN?
They call it an angioseal?
They do have angioseal too. That's why I said there's several different ones. Star closures one, angioseal. But most of them are collagen. And then they will eventually absorb after it's healed. Yes, you do. You pull those, and you're specially trained to do that.
So when somebody goes in and has a stent, what kind of hospital stay is it? Is it a day thing?
No, well, where I have my students at Galicia, those people will usually stay overnight. And then they go home the next day. So they stay on the interventional unit, which is, all the nurses at Galicia are ACLS certified. But the interventional unit just has a little bit more education and what happens if that should open again and that kind of thing. So they stay in that interventional unit overnight. Sometimes there are patients in the hospital already and they come in and have a heart cath, or they go in to have a heart cath and they go back to the floor. And also when they're in there with that balloon, they can open that more than once. And they want to keep opening it until they get at least a 50% flow rate.
How do they measure that? when they open it, like I'm looking at the picture,
Mhm.
and when they open it, it looks like it's green, and then the image of that flow rate.
They wouldn't until they take that out.
Okay, all right, then they can go back.
It would be, they'd be able to tell by the size of the artery when they deflate the balloon.
Okay.
Okay. Okay, let's see if I covered everything. So after they've had their lines pulled, or let's say they come out with their lines pulled, they have a angioceal or a star closure in there. And you have to assess that patient every 15 minutes for so long. It's usually 15 times 2 hours for an hour, 30 for an hour. So actually, sometimes it depends on what's going on with the patient. It may be more than 15 minutes that you do it. And when you assess that patient, what kinds of things do you think you need to look at?
We need to look at their
At the
insertion
site.
site.
At the site,
Make sure that they don't have any redness or swelling or.
what else are you gonna make sure it is when you're feeling it? You want it to be
Make sure
what?
it's not warm.
You want to make it, sure it's nice and soft, and that they're not developing a hematoma. If they're developing a hematoma, it will become painful, it will be hard, it won't be that nice, soft, and then you just maybe have some bruising over it.
Right, the book says that they have to keep their legs straight.
You have to
For the
keep
first
your
8
legs
hours.
straight for up to 6 hours. Okay? Especially if you don't have one of those closures in there. And when they're having to keep their legs straight, they can have their head elevated a little bit. Not very much, maybe 20 degrees. Okay? But they're not allowed to lift their head. Just sit there and try putting your head forward. Where do you feel pressure at?
You're growing.
If you're pulling your, not just putting your head down, but lifting your head like you're laying down. You feel pressure down in your abdomen and your groin area. So they don't want that going on, okay? Especially if you're laying flat and you go to sit up, you're gonna be putting pressure in your groin. So you would need to be alert to that patient and make sure that you're finding out if they need to go to the bathroom, because they're gonna have to use bedpan. And how are you gonna roll them to put them on the bedpan? To what? Carefully, yes.
It's on the side. Well, if they had it on the right side, I'd say you'd probably roll them to the left.
You roll them to the affected side. Once they have stabilized, their vital signs have stabilized, and they usually wait about 30 minutes, and then they'll let them go ahead and eat. They just want to make sure they're not going to have any nausea and vomiting. They give them something to drink, make sure they're going to be able to keep that down, then they'll let them go ahead and eat.
So how traumatic would it be if somebody was on it?
Think what it would be doing to your groin. Lots of pressure. So you don't want them to be sick.
So we'll just start with like ice chips then?
No, usually just some water or something to drink, some Sprite.
If they have a known trouble with anesthesia, would they just preemptively?
They don't really give them
kind of-
anesthesia, they don't put them to sleep.
I know, but I mean, I know they're not going under general, but if they have had a history of a reaction to the anesthesia, you know, they potentially might react to the sedation, but they just kind of preemptively give them an
Probably give them some
antibiotic.
Zofran. And I'm sure that when they do this assessment, or even before they come in and they've done some of the assessment in the hospital or the doctor's office, they would know, they'd be some of the questions they would ask them in that pre-admission or the admission assessment, is if they have any problems with nausea after surgery. Okay, so usually, once they're all done, maybe they're gonna go home that day, or they're gonna stay in the interventional unit, that's when they'll start the Plavix usually, is right after they've done the stent. Sometimes they'll give them aspirin and Plavix. And if they've actually had an MI, this hasn't been an intervention before they've actually had an MI, they've had the MI, they may start them on beta blockers and ACE inhibitors. And if you look in your book on page 838, and it's chart number 40-4, those are going to give you those meds.